Hello, everyone, and welcome. Good afternoon. My name is Dee Morgello from Access Medical Education. On behalf of all of us at Access, I would like to welcome you to our educational event today entitled Advancing Interdisciplinary Care in Prostate Cancer, Clinical Updates for Urology and Oncology Healthcare Professionals. This event will last approximately 60 minutes. For your convenience, all lines have been muted. Next slide, please. This activity does offer one contact hour for physicians, pharmacists, and nurses. I would like to call your attention to the right side of your screen in the control panel and to the section entitled Handout. There are two PDF documents in this section for your convenience. The first one is called the whole syllabus. This is a slide presentation that you could follow along if you'd like to as Dr. Sartor presents the material today. You can print this document or save it to your desktop. Second document is a PDF document called Claim Credit Instructions. After the program today, you will be claiming your continuing medical education credits through an electronic portal. This is a document on step-by-step directions on how to do that. At event's conclusion, you will receive an email from us that will provide the link that is also in that PDF that takes you right into the portal where you will complete an evaluation, a post-test, and print your own certificate of attendance. Now, pharmacists, you know that you don't receive the certificate of attendance, that your record will be automatically uploaded to CPE Monitor once you enter your accurate NAPD EPID number and month, day of birth. So please be sure to have all that in front of you when you enter the portal. Next slide, please. I will pause as you review the disclaimer and disclosure of unlabeled use statements shown on this slide. Next slide, please. Dr. Sartor would like to disclose the financial interest relationships or affiliations on your screen now. I will pause as you review the financial disclosure information. This educational activity is supported by an educational grant from Santa Fe. We will not be taking verbal questions today because our attendance is so high, so thanks to each of you. However, the question box has been activated. It is right above the Handout tab on your control panel to the right of your screen. You may type in a question at any time, and if time permits at the conclusion of the activity, Dr. Sartor will address a few select questions. Have an excellent hour of excellent education. We're so glad you're with us. Now it is my pleasure to welcome Dr. Oliver Sartor. Dr. Sartor, the controls are yours.
Great. Can you hear me okay?
I can. You sound great.
Okay. Just want to make sure. Yeah, so we actually have a very ambitious agenda, and I hope to be able to make it through. There's a lot of slides and a lot of concepts, so at times I'm going to be moving pretty quickly. We're going to be trying to look at advanced prostate cancer with a little bit more emphasis on the metastatic disease, what we call metastatic CRPC or the castrate-resistant disease. And as it turns out, this is really an area of rapid change, and we are beginning, but certainly not there, to develop individualized treatment strategies. And there are a variety of guidelines, but they're actually not very helpful. So I'll show you the guidelines, but I won't dwell on them because the guidelines are deficient in so many ways. And then in the beginning, at the very end, we'll come back and talk about some coordination of care that might be able to benefit office-based treatment. But that's where 99.9% of the patient care occurs. First of all, I'll go off with a pre-assessment question. Very recently, there was a trial called the Latitude trial, and it reported increased overall survival and radiographic progression-free survival in men with newly diagnosed castration-sensitive disease was metastatic. And Which one was that? Is that docetaxel, abiraterone, enzalutamide, cabazitaxel, or unsure, A, B, C, D, E? And I need perhaps a little bit of guidance on this. I don't know how long I hold in order for people to be able to answer this question.
Just give us. Yep, Dr. Sartar, I'm on. We're going here. We're at about 50 some percent. So I'm going to go ahead and close as of now. And well, hold on. Give it a little bit more time. All right, I'm going to close, and we can go ahead and move to the next slide.
And we have a pre-assessment question number 2 with radium about whether or not it might have demonstrated efficacy in the chemotherapy naive population, post-docetaxel, both or unsure. And so we'll try to cover that.
And we are collecting here, so okay, so we've closed it, and you can go ahead and advance to the next slide.
And question number 3, which of the following is a preferred first-line chemotherapy for symptomatic metastatic CRPC, docetaxel, abiraterone, enzalutamide, unsure?
And the poll is open to the audience. It is closed. You can go ahead to the question 4.
And for question 4, cabazitaxel and prednisone is the appropriate treatment option for patients with metastatic CRPC in which of the following settings? First line, progression after treatment with docetaxel, after abiraterone, after enzalutamide, or unsure.
And poll is closed.
And number 5, sickle cell T should be considered in asymptomatic or minimally symptomatic patients with which of the following characteristics: good performance status, estimated life expectancy greater than 6 months, less than 6 months, but similar good performance status, estimated life expectancy of greater than 6 months with hepatic mets, or life expectancy less than 6 months with hepatic mets, and unsure.
And closed. Moving on to the last one.
And the last one is pre-assessment question number 6, which is true of an all-in-one multidisciplinary model. Patients are evaluated by only one specialist who speaks for the entire group. You discuss treatment with specialists on different days and may decrease time and travel burden on the patients, or D, unsure.
Couple more seconds for everybody, please. All right. It's all yours. Back to you.
All right. So really we're going to start looking at advanced prostate cancer, and I think one of the things that's relatively intriguing is we really are beginning to have a different era with hormonal therapies, targeted therapies, immunotherapies, chemotherapies, surgeries, radiations, nuclear medicine, and molecular and genetic testing all beginning to interplay in terms of being able to provide optimal patient care. And it's different now than it was even in the recent past, and it's quite intriguing. I've been involved with this field for 27 years. I've never seen the pace of progress so fast as it is today. When we begin to look at the clinical states, and this is a reasonable model to begin to think about it. We have hormone-sensitive disease. We have disease recurrent after hormonal therapy. We have those individuals with no metastasis. We have individuals with metastasis. And each of these represent a disease state that is fairly common for our patients. There's local disease, where we may put people on surveillance or local therapies, surgery, radiation, rising PSA after a local therapy. Maybe it's rising PSA after the induction of hormones. There's no real standard of care there today. Variety of metastatic patients after hormonal therapy, and then of course you can be diagnosed initially with metastatic disease. First of all, I'm going to start talking about those individuals with metastatic disease, and one of the more interesting things that we found just in the last year from a New England Journal article published 2016 was about 12% of men with metastatic prostate cancer actually will end up having a mutation in part of the DNA that they're born with. And the most common of this sort of new mutations that we know about, and of course there may be more because these are just DNA repair, is BRCA2, which is a breast cancer gene. And this has long been known to be associated with breast and ovarian cancer, but more recently we find this: 5.8% of men are going to end up having a BRCA2 mutation or thereabouts. Other mutations include CHEK2, ATM, BRCA1, RAD51D, PALB2, a smaller percentage of patients. If we look at men with metastatic disease, the number of these germline mutations is much higher than it is for men with localized prostate cancer, which is about 4.6%. Why are these mutations important? They often confer a relatively poor prognosis, early age of onset. They have implications for future treatments, such as PARP inhibitors, platinum, potentially PD-1 inhibitors, and tomorrow maybe much more. Has implications for family members that may include increasing monitoring at an earlier age and even prophylactic intervention. If a woman has BRCA1 or BRCA2, quite commonly after their childbearing years, they'll end up having a prophylactic mastectomy, oophorectomy, so a major life decision. Major surgery can result from understanding these mutations, particularly in the females. And there are a variety of things that we don't know, and I do want to emphasize that mainly what we have today are European-centric populations. North America, Europe is where most of this data is coming from, and I think we need to learn a lot more tomorrow, and that's just one small issue. Now, I'd next like to focus on therapy for these patients who come in with overt metastatic disease. And I think at this point we've now reached some consensus, we've reached some controversy, and we've reached some change. We have a consensus that high-volume metastatic disease, and I'll show you some data here in a moment, is suitable for androgen deprivation therapy, or ADT, plus 6 cycles of docetaxel. And we have some controversy because in the low-volume metastatic disease, we have some data that is a little more equivocal. And then very recently, presented in June of this year at ASCO, we have 2 new trials with Stampede and Latitude that, quite frankly, are game changers because there's new data with ADT and abiraterone that shows a substantial difference. So let's look at some of these data. The slide on the left is from the New England Journal that demonstrates that patients with high volume metastatic disease, and high volume is defined as visceral metastases with 4 or more bone metastases, one beyond the pelvis or vertebral column. Our visceral met would be liver, lung, something like that. And this definition of high volume, there was a hazard ratio of 0.6, which means a 40% reduction in the risk of death, and about a 17-month difference in median survival between the androgen deprivation docetaxel and the androgen deprivation alone, which is pretty substantial. I mean, 17 months, if you're only expected to live about 32 months, is honestly a pretty big difference. Now, for patients with low volume disease, you can look on the right, and yes, there was a pretty good hazard ratio, but the confidence intervals were large and overlapped 1. The p-value is 0.11, which is not statistically significant. And this sort of use of docetaxel in low-volume disease is the subject of some controversy. Now, we have a new study called Latitude, and it looked at androgen deprivation and abiraterone and prednisone versus placebo with ADT. So everybody got standard of care. And in order to understand who went on this study, you had to have 2 out of the following 3 factors. You either had to have a Gleason 8 to 10, that was one factor that was considered. You have to have a visceral met, so something in the liver or lung, or you had to have 3 bone mets. And so if you had a Gleason 8 and 3 bone mets, you'd be eligible for the study. If you had a Gleason 7 and 2 bone mets, you would not be eligible for the study unless you had a visceral met, but most patients don't. Nevertheless, you can see that these patients with clear metastatic disease have a substantial benefit with the addition of abiraterone, the hazard ratio of 0.62. You think about that in an inverse manner, it means a 38% reduction in the risk of death, good p-value, excellent radiographic progression-free survival, and you see the hazard ratio of 0.47, so reducing the risk of radiographic progression by more than 50%. When you look at the PSA progression, it's really quite dramatic. In the conventionally treated patients with ADT, it says placebo, but it's androgen deprivation, which has been the convention since 1941. You see that there's a median of only about 7 months worth of abiraterone. It's about 32, 33, and that hazard ratio is 0.7. So there's a 70% reduction in the risk of PSA progression. We looked at the adverse events. There are, some adverse events that I think that people need to be aware of with this abiraterone and 5 milligrams of prednisone. Hypertension is more common in the abiraterone prednisone. Here you can look at grade 3, 20% versus 10. Hyperkalemia, 10% versus 1. ALT, which is a liver function abnormality, 5 versus 1. So, if you begin to separate this out, there's about a 10% risk of hypertension above placebo, 9% risk of hyperkalemia above placebo, and about a 4% risk of substantial liver issues above placebo. Now, if you look at the other issues, hyperglycemia, etc., there's really not much difference. And yeah, there are a few events that you have, like a cardiac disorder was maybe 2% more, but it's pretty small. Taken together, it actually was quite well tolerated, and I've used a fair amount of abiraterone in my practice, and it's a well-tolerated drug as a whole. Now, the second study, also presented at the same ASCO, also presented at New England Journal, published online on June 3rd for this one. The latter two was June 4th. And you can see again that there was a substantial improvement in overall survival in patients with metastatic disease and failure-free survival as well. Failure-free survival means that there is PSA progression, death, radiographic progression, and again you see pretty dramatic changes here. For the overall survival, the hazard ratio was 0.61, not shown here, but it's 39% reduction. For non-metastatic disease, there really had not yet emerged a difference in this group of patients with non-metastatic disease in overall survival, shown on the left, but the failure-free survival on the right, it does show a substantial difference. So we have to probably wait longer in order to determine if those are clinically relevant issues. These are strong studies. They're positive studies, but there's several criticisms too. The crossover treatments were limited in the control groups. The Latitude study was done in a large number of countries. Many of the patients who were randomized were randomized in areas where there necessarily was not good access to abiraterone and enzalutamide. So only a minority of the control patients received abiraterone or enzalutamide after progression, and that is a little bit problematic. There's also a lack of surrogate endpoints. Survival, in fact, was very dramatically positive, but, I'm actually hoping that we can have good studies done where people don't have to die to conclude that the drugs are effective. There also was no molecular biomarkers, and that's an issue that we're beginning to think about hard in the near future. Some implications for the Latitude and New Stampede is that upfront abiraterone prednisone will change the biology of the tumor. The effectiveness of subsequent therapies are altered in potentially undefined ways. We know that cross-resistance between Abi and Enza are well documented, but we don't really know how this upfront treatment is going to be changing things. And we're also beginning to change the definition of what we call castrate-resistant disease. Is that castrate-resistant with docetaxel on board in the beginning, or abiraterone on board, or the old style? And really what I can say is that we're beginning to sort of change our definitions and change our patients from what the progression actually means for patients treated up front. By the way, one of the things that I think that this does in an important way is that neither the older ADT alone nor the ADT plus bicalutamide or flutamide, which are the old anti-androgens, really represent current standard of care. So if somebody with metastatic disease at the time of their diagnosis is getting old school therapy with ADT alone or ADT bicalutamide, that's not really the standard of care. Now, this has just changed now. So this is truly a new finding with the original presentation in June, and the New England Journal article is online in June as well. But this is something that has changed, and a lot of people are not aware of it yet. Now, should we be using ADT docetaxel, ADT abiraterone, or maybe even a triple therapy to combine everything? The answer is we don't know about triple therapy. That's still an unknown. But we do know from a presentation by Matt Sides at ESMO, which was literally 2 weeks ago in Madrid at the European Society of Medical Oncology, that overall survival is the same for the docetaxel and abiraterone. So now we know that's about the same. Now, next we'd like to look at the issue of oligometastatic disease. So this is the person who might have only one metastasis. Here you've got an individual with an iliac bone met, PSA 2.7, nothing else showing on the scans. What do we do for this type of patient? And there's a lot of discussion. I mean, we don't really know if you ought to be operating on these patients and treating the prostate. Should we just be putting them under observation because they feel fine, and maybe you don't even want to give them the androgen deprivation? With regards to the SBRT, that's stereotactic body radiotherapy. Do we want to try to treat these areas of metastatic disease? Do we want to use the old forms of ADT, the new forms of ADT? Because the Latitude trial really didn't address these patients with just one metastasis, but the Stampede trial did. And in the Stampede trial, they didn't break out this subset, but it was positive in metastatic disease. Do you want to use androgen deprivation and radiation? Androgen deprivation, you want to try docetaxel here, maybe a little less data for the docetaxel. You want to put everything together and radiate the metastases. I say something for everyone, a true dealer's choice. No one really knows the right answer, and the current trials are really somewhat limited. We just need to have more data in this space. So we go back to our disease states model, and when we look at it, the individuals with overt metastatic disease, when they progress, are going to have metastatic disease that is castrate-resistant, recurrent after initial hormonal therapy. Now, you can get to this metastatic CRPC also by coming the other route. You have localized disease, treatment and failure, and then a rising PSA and then metastases. So you can kind of arrive at this state in two different ways. And depending on where you are geographically, you can come to these more commonly or less commonly. In the U.S., it might be that the majority of patients actually come in after local treatments. On the other hand, if you go to Malaysia, the vast majority of patients, or to China, most of the patients have overt metastases first and then progress. So a lot of geography comes into play. Now, these are the critical trials that have been shown to prolong survival for metastatic castrate-resistant prostate cancer. And there's docetaxel, simple cell T, abiraterone, enzalutamide. These are all in the first-line setting, cabazitaxel, abiraterone, enzalutamide in the post-docetaxel setting. And then radium trial actually had a stratification for chemotherapy naive or post-docetaxel and was positive in both subsets. And you can see the hazard ratios are pretty similar. The survivals are a little bit different, but a lot of that depends on the patient population. You know, the docetaxel patients were predominantly asymptomatic, and in the abiraterone enzalutamide, they had to be asymptomatic and chemotherapy naive. The simple cell T, they had to be asymptomatic or minimally symptomatic. You can see just simply by the stratification on the number of months that you see here, a lot has to do about the patients being treated more so than the drugs that are being utilized. The cabazitaxel is only approved in the post-docetaxel space, whereas Abi and Enza are approved in both spaces. So there are a variety of differences, and if you look, you know, these are major publications over the years with changing data. Now, how do we begin to select and sequence our therapies for individualized approaches? And I'll just say that this sequencing in combination and the utility of molecular biomarkers, I call them the great unknowns. We just really don't know how to do this today, and so we're exploring. So the next part of the talk, we're going to be a lot more speculative and pointing out some of the problems we have rather than necessarily saying how great we are. And when we look at the randomized trials, we have clear lifelong activity for abiraterone, prednisone, and enzalutamide, cabazitaxel, and radium in the post-docetaxel space. But we don't have any level 1 evidence for the post-abiraterone, the post-enzalutamide, post-simple cell T, post-cabazitaxel, or post-radium space. So we've got these compounds, but they've never been compared to one another. And today, most of the patients are going on abiraterone or enzalutamide as their first therapy for CRPC, and then we don't really know what to do next. So it gets to be an issue because we love level 1 evidence. I love level 1 evidence. And we've got a lot of level 1 evidence, but nothing that is compared to one another. And that creates its problems. Now, so what do we know about some of these sequences? Now, one thing I can say is that for abiraterone and enzalutamide, which are two popular metastatic CRPC agents, that whichever one you use first usually lasts a long time in terms of duration of treatment. Whichever one you use second probably doesn't last. And it turns out that I'm not even sure whether or not back-to-back oral hormones is really the best option, I mean, there was a recent study, and I can quote the statistics, it's pretty amazing. If you're on enzalutamide, and then what they wanted to do was try to figure out if you added abiraterone to enzalutamide. So enzalutamide failure, abiraterone at the time of failure, and hey, did you do better by the addition of abiraterone? The response rate was 0.8%. The response rate was less than 1%. That was the Plato trial that was presented by Gerda Tard at ASCO this year. So, using these back-to-back hormones just may not be the best option. You do get a little higher response rate when you go from Abi to Enza as opposed to Enza to Abi, but that's a whole different story. So I've begun to sort of look at these issues about sequencing, not in terms of real large prospective trials, but rather in smaller subsets and looking at things like PSA decline rates, which are not necessarily the same as clinical benefit. So if you look at the docetaxel post-abiraterone in 100 patients in the Cougar 302 trial, which is an abiraterone trial, it turns out that about 40% of patients, when they get docetaxel, will have a decline. If we look at third-line enzalutamide therapy, so here we have some data with docetaxel first, then abiraterone, then enzalutamide, it actually turned out with a 29% PSA decline, and so that's better than you might expect. So enzalutamide after abiraterone is probably a little more active than the opposite. So that gives us a little bit of insight. We have third-line cabazitaxel therapy with docetaxel, abiraterone, cabazitaxel, and here we have about 40.5 in one study. This is Camille Pizarro and colleagues out of European Urology. And then here's another study looking at third-line cabazitaxel, docetaxel, abiraterone, cabazitaxel, and you turn out with about a 35%. Now, in the TROPIC study, which is the original post-docetaxel study, the 50% decline rate was about 39%. So you actually seem to be doing pretty well with the cabazitaxel in this third-line setting. And by the way, there was no correlation between response to cabazitaxel and duration on the docetaxel abiraterone in that particular study. And it is something that, we now are thinking that cabazitaxel can remain active in these patients progressing after docetaxel and AR targeted therapy. Now, one of the other sequencing questions is, since cabazitaxel was clearly active after docetaxel and led to an approval in that space, the question was, would cabazitaxel be better than docetaxel if you give it to chemotherapy-naive patients? And this is a big trial. Actually, I presented it last year at ASCO in the presentation. Senior author of the manuscript, which just came out. And what we can say is that they looked at 2 different doses of cabazitaxel versus standard dose docetaxel over 1,100 patients, and the bottom line is the overall survival really was not any different between the 3 arms. And what we can say is that docetaxel remains the standard of care because cabazitaxel wasn't better. Now, cabazitaxel is a good drug here. Don't get me wrong. Cabazitaxel is an active drug. It's just as active as docetaxel, but docetaxel is a cheaper generic drug, and it's been approved in this space, and cabazitaxel is not FDA approved in this space, and it simply did not show superiority against the standard of care. Now, there's a second study that I think is important here, and this isn't about sequencing. This is post-docetaxel patients going on to get cabazitaxel and looking at 2 different doses, the 20 milligrams per meter squared or the 25 milligrams per meter squared. And again, 1,200 patients, and looking at OS, there was no difference in the overall survival. Hazard ratio was 1.02. Now, this really means in the trial design that there was a non-inferior outcome, as statistical speak, but a non-inferior outcome for the lower dose of the cabazitaxel. And the formal way of stating it is that the upper boundary of the hazard ratio was 1.184, which was less than the margin that was pre-specified at 1.21. And it turns out that you get a little better safety when you use the lower dose, but you don't lose the efficacy. And then in September now, 2017, the FDA has approved the lower dose as being appropriate for patients with metastatic CRPC progressing after docetaxel. So that's important. Now the guidelines here, and I'm not going to dwell on it a lot, because the point I really want to make when you look at these guidelines is that they give you first-line guidelines, simple cell T, abiraterone, docetaxel, enzalutamide, alternative chemotherapies, radium, clinical trials, secondary hormones. But all they do is they give you a list. They don't tell you which one is best. Same thing is for progression after abiraterone. They give you a list. Progression after docetaxel, they give you a list. So if you're a doc and you like guidelines, then sure, you got a bunch of guidelines that you can follow here, but you can do everything from best supportive care to whatever clinical hormone you want to give to clinical trials and simple cell Ts. I mean, you know, there's no guidance over what to actually do. Going to the molecular stratification now, this is an area very, very active. We're trying to figure out how you can treat one patient differently than another. And one of the first studies that came out looking at a predictive biomarker is the presence of something called AR-V7. Now, what is AR-V7? AR is antigen receptor. V7 is variant 7. It turns out that there is a splice variant. And when you have this splice variant, you take away the hormone binding part of the antigen receptor called the ligand binding domain. And if that happens, it turns out that you're much more likely to be resistant. So here they are, the positive patients. I'm a little colorblind. I think that's red or orange. AR-V7 negative is, I think that's blue. But you can see that there's a real difference in the enzalutamide-treated patients as to whether or not they're going to be responding based on their AR-V7 assays at baseline. And you can see the same for the ABI here. So this kind of got people excited. But it turns out that there are some imperfections. Number one is here you've got almost a perfect dichotomy, but it turns out that that perfection is not completely held up in more mature trials. It is helpful, but a lot of people don't have circulating tumor cells. If they don't have circulating tumor cells, you can't do this assay. One thing that has come forth is different ways of looking at circulating tumor cells. Those are CTCs. And here you're using an antibody to bind to the V7 protein, and you can see that, first of all, there's very little in the way of AR-V7 positivity in patients receiving first-line therapy, but second-line therapy, you start to pick up more, and third line you pick up more. But if you're lacking the V7, you might be a responder. If you've got the V7, you're more likely to be resistant. And so this is a newer way to do it, and this is a trial assay in development. This is taxane responsiveness, and I think this was a little bit interesting. So again, these V7 patients, I think that's orange right there. You can see that the V7 patients are going to be responsive to taxanes in a substantial number of patients. So that's a good thing. Now we kind of have the idea that you might be relatively resistant to the secondary hormones, but you might be sensitive to some of the taxanes. In this case, it was either the enzalutamide. It was either, excuse me, I said enzalutamide, but that's incorrect, cabazitaxel or docetaxel. We're also beginning to look at circulating free DNA alterations. This is something that a lot of people are looking at now, looking at antigen receptor gain or amplification, certain mutations that are present. I mean, here's one they call the T877A. If you really want to get confused, they now call this the T878A because they changed the numbering system. but you can begin to see that you can pick out molecular features of people who've progressed after enzalutamide or abiraterone. And you can actually predict what's going to happen. So if you have an amplification, an AR gain, or that you have an AR mutation of a certain type, the 702 or the 878A, these mutations and AR gains are predictive for having resistance. So this is another way to kind of predict what might work in a particular cell and what might not. And here's the overall survival. If you've got the androgen receptor aberrant, which would be either amplification or the 702 or 878 mutation, you can see that the survival is really not very good compared to the group that is copy number neutral. Which drug for which patient? Taking it on a little bit longer. Choosing which drugs might be effective, not just predicting resistance. So when I was showing this AR amplification, mutation, ARV7 story, it's about predicting resistance. Now we're trying to pick out drugs that might be effective. Actually, before we get into this, I'll just mention briefly the Synergy trial. This was a way of looking at the opportunity to switch early, going from docetaxel to cabazitaxel. Very small trial, 22 patients on cabazitaxel because they're randomized 2-to-1. And if they didn't achieve a 30% PSA decline, then they switched the taxane. And when doing this, it turns out that the early taxane switch is associated with improved PSA survival rates. Now that's, I'm sorry, improved PSA response rates. I said survival, that's a mistake. Improved PSA response rates. The taxane-induced shifts may be a good way to go, but clearly we need bigger trials before we get excited about that. One thing, and this is returning to the theme of DNA repair defects, it turns out that DNA repair defects can be present when you're born, and these are so-called germline alleles that you see in these black diamonds along here. But it turns out you can also have a variety of alterations that change the copy number, such as 2-copy loss, or maybe you have a frame shift mutation or nonsense mutation, a variety of ways that you can end up with changes in the DNA repair. If you add this up, this is actually about 20 to 25% of patients. So that's pretty substantial. And now we have some preliminary evidence that PARP inhibitors, such as olaparib, not FDA approved, but in a small trial suggested potential benefit in 14 out of 16 patients. Now there are multiple clinical trials with olaparib. There's also some data with platinum regimens, docetaxel platinum regimens, can have a very favorable clinical course if they have a biallelic inactivation of BRCA2. And that's kind of a new thing. We don't think about using platinum in our prostate cancer patients as a rule, but now we've got an opportunity to think about this in a little bit of a different way. This is a cabazitaxel carboplatin regimen in an aggressive variant of prostate cancer. Now, the aggressive variant is defined in a lot of different ways. There are 7 different definitions of aggressive variant, including such things as a liver metastasis or lytic lesions and high LDHs. It's not biologically defined. But actually, these are tough patients, and everybody knows these are tough patients. And when you looked at the cabazitaxel carboplatin, you look at the waterfall plot, a 50% reduction in PSA was found in 62% of the patients. That's really good. Now, cabazitaxel's performing well at about 41%, very similar, I might add, to the TROPIC trial, coming in right about 40% too. But you can see in this bad variant, aggressive variant patient as defined by this particular cohort treated at MD Anderson, that you have 62%. And that's quite good by using the combination of cabazitaxel with carboplatin. One of the other things that's interesting about choosing therapy is there might be more mismatch repair mutations, and these are the genes that are MSH2, MSH6, MLH1. These are things that are copy number or mutation variations, and many of these patients end up with hypermutated tumors. When you have mismatch repair, you end up with hypermutated tumors. And there have been some data to look at pembrolizumab, which is a PD-1 inhibitor, and this one is actually in trials with enzalutamide, some very, very good responses in occasional patients with the addition of this PD-1 inhibitor. Now, this patient had an MSI high, which is the mismatch repair gene. But we clearly need to know more about this. There are clinical trials ongoing, but not FDA approved. So we don't want to talk about that too much. But what is FDA approved is that if you have a high microsatellite instability, or DNA mismatch repair deficiency, and this is predominantly with MSH2 and MSH6 in the context of prostate cancer, that you can end up treating with pembrolizumab in an FDA-approved manner as of May 23rd. And by the way, about 10% of all cancers worldwide might fall into this category. So it's a really big approval. That was a FDA news release in May. Another interesting factor is a molecular change called PTEN loss. And if you look at PTEN loss, you can see that there is an improvement in some of these events, progression-free survival, with the addition of an AKT inhibitor, ipatasertib, which is now in phase 3 clinical trials. If you have no PTEN loss, then there's no difference between using abiraterone in combination, but here you look at the AKT inhibitor plus abiraterone, and this is better, 4.6 months, 11.1 months, and the p-value is quite good here. Another thing that is quite interesting is the PSMA binding molecules. PSMA is prostate-specific membrane antigen, and you can link these to therapeutic isotopes such as actinium-225, lutetium-177, bismuth-213. Here's a chelator right here. You can stick that isotope on, and when you're doing this, you can actually treat a number of patients that might be difficult. Here's a waterfall plot for patients that are having declines in their PSA. And we're beginning to get more data on this as well. So kind of to begin to wrap up this part of the talk, and then we'll go on to the next part, is that the CRPC is evolving into molecularly targeted disease for a significant subset of patients. We're thinking about DNA repair. We're thinking about mismatch repair. We're thinking about PTEN alterations. We're not quite there yet when it comes to FDA-approved therapies, but the clinical trials are ongoing, and I have a sense of optimism that some of these clinical trials are going to be working out. The androgen receptor remains a very important target, and much we gain from treating CRPC with new AR targeting agents, but cross-resistance, as I showed you, is a major issue. So, whatever is second line, you don't expect to gain a great deal from. Taxanes still have a very important role. I say an important role, a very important role. They're the ones that can be active when the V7 is positive. They're the ones that can be active when you've already progressed after your abiraterone. And clearly, we're in a position now where we're making progress. Much progress has been made, but there's much more progress that we need to make. So this is really, really evolving. Now I'm going to come through a little bit of some of the case studies, and gosh, there's a lot of things that you can kind of put in the mix, and I've got asymptomatic and minimally symptomatic and symptomatic and good or poor performance status and visceral mets and prior therapies, resistance to prior therapies, and symptomatic bone mets and life expectancies and predicted outcomes by the various molecular markers and patient preferences. There's a lot of stuff that you have to take into consideration. I mean, we go through an extensive decision-making process when we're treating these patients in clinic. Here's a patient I'll just take you through. We got a 66-year-old guy. He's got metastatic CRPC. He's got a PSA 145 and rising. He's got some mild diffuse bone pain. ECOG performance status 1. Small liver mets and bone mets. No prior therapy for CRPC. And he gets germline genetics, but those are pending. Now, this individual, if it's a relatively mild symptomatic patient, could be eligible for Cipla T, although I'll tell you it wouldn't be my choice. Abiraterone is certainly a reasonable choice. Enzalutamide a choice. Docetaxel prednisone a choice. Radium is not a choice because you've got liver metastases, and that's an exclusion for the bone-targeted radium therapy, which we didn't really talk about a lot, but radium is a very interesting therapy. So you got all these treatment options, and what do you do here? And most patients today, in fact, the vast majority of patients today will start with either abiraterone or enzalutamide. And the rationale is for Cipla T, these patients are going to be best suited for the low PSA, low volume. Abi-Pred, well tolerated, good drug, combination, good response rate. Enzalutamide, good drug, good response rate. This particular patient ended up on Abi-Pred instead of enzalutamide. Docetaxel is a chemotherapy, perfectly appropriate to start this patient on chemotherapy, but only a minority of the patients in America today are starting on chemotherapy. So he goes on Abi-Enza, PSA declines to about 78 or so, then he begins to increase. At 8 months, he's beginning to have radiographic progression in the bone, but he's got stable liver mets. ECOG performance status still 1, so now you've got a patient who's progressed on the Abi-Pred and is going to need another therapy. So what do you do now? Docetaxel, enzalutamide, radium, and I can tell you when we begin to look at this that the docetaxel looks like a good option. By the way, now we get our germline genetics back, because remember I did that at the beginning. This is a metastatic CRPC patient. He's got a VUS in MLH, says 12. I think that should be MLH1. But the bottom line is that variant of unknown significance doesn't mean much. So we're trying to figure out what to do and the cost and the patient preferences and benefits and the harms of therapy. This patient needs to go on docetaxel. And interestingly, there is a trial that has gotten very little publicity, but it is a good trial that shows that 50 milligrams per meter squared every 2 weeks of docetaxel may actually be superior to every 3 weeks. It was overall survival as a secondary endpoint, but the Q2 weeks was better. Now, going through the rationale, enzalutamide, small response rate, docetaxel, about a 40% PSA response rate. This Q2 week regimen outperforms the Q3 week in this important publication by Dr. Kelly Kumku-Lieutenant in Lancet Oncology, and it's an interesting approach, and by the way, one that I use. But radium is not something that we focus on in the liver metastasis setting. So the patient gets docetaxel and uses the Q2 week regimen, gets 14 cycles, has initial PSA decline of 50%, does well, and then has this slow PSA rise followed by a modest enlargement of the previously documented liver mets. So now the PSA is going up. Now the liver mets are starting to get bigger. They tolerated the docetaxel pretty well. And what do you do now? They did some nail bed changes, modest low extremity edema. Enzalutamide, abiraterone, cabazitaxel carbo, clinical trial. You've got a variety of things that you could do. Now, enzalutamide, sure, you can go back to enzalutamide. The patient's never seen it, but they were resistant to the abiraterone previously. We know about the cross-resistance issue we've talked about. Abiraterone re-challenge, probably not a great idea. Cabazitaxel, very reasonable, given the response to docetaxel, second-line setting, and that certainly is extremely reasonable. The cabazitaxel carboplatin, also very reasonable. Liver mets in the post-docetaxel setting. This falls into this aggressive variant prostate cancer on the abstract I showed you. That could be very reasonable. Now, you could argue that this patient will have a liver biopsy and get genetic analysis on the liver. Certainly that could be an option. Maybe the circulating free DNA analysis, clinical trial. There's a whole bunch of things that one could actually do here. The patient starts cabazitaxel, by the way, having less nail bed changes, less neuropathy, less edema than the docetaxel. I choose, the 20 milligrams per Q3 week dose with prednisone 5 milligrams BID based on the Prosilica trial. Prosilica compared 20 and 25. And this is a good regimen, and he had a good response to the prior docetaxel, tolerated the docetaxel well, and that's part of the key decision here. So there's some good things. All right, we don't have much time left, so I'm going to kind of blow through this last bit pretty quickly. Just a few comments. When you give the drugs, this will be in your packet. It's FDA approved. I'm not going to concentrate on that. Here's the way you give cabazitaxel, docetaxel, radium, simple cell T. Way too many words. I'm not going to talk through that. ASCO ONS standards, creating safe environments, treatment planning, consent ordering, monitoring. It all goes together. You have to do it all. NCCN guidelines, well, they're great, but they're not so great. I mean, I can take you through them in detail, but in the end, you end up saying, well, I can do this or I can do that. There are no head-to-head comparisons. I really take a lot of emphasis on patient outcomes, encourage clinical trials, and refer early to medical oncologists when we can. ASCO says to inform the patient and think about cost. We do. Care coordination, you've got to be able to develop care coordination guidelines and be able to work with them in your clinic. We do. It's not rocket science to talk between urologists and oncologists. And you can put together multidisciplinary clinics, and we do. We have multidisciplinary clinics with both radiation as well as the urologist. So I'm actually a medical oncologist that works in the urology clinic. I work next to my radiation oncologist, and we bring our support services in. So we operate in a true multidisciplinary clinic. Clearly, you can discuss treatment with a specialist on the same day. You can decrease the time and travel burden on patients, get better communication, and actually we do it all in the same space. So it's kind of a win all the way around. There are lots of different models. You can have the urologist kind of set things up and bring everybody in, or we do it at the medical oncology level. Tumor boards are great, and we discuss our patients at tumor boards. We talk about clinical trials, etc.